Ladies and gentlemen, thank you for standing by. Welcome to the Geriatrics-Competent Care webinar series and today's webinar on multidisciplinary geriatric assessment of the older adult. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session. Instructions will be given at that time. If you should require assistance during the call, please press star, then 0. I would now like to turn the conference over to your host, Renee Marcus Houghton. Please go ahead.
Thank you, Joe, and welcome everyone. Again, my name is Renee Marcus Houghton, and I'm a project director at Community Catalyst out of Boston, Massachusetts. We thank you so much for joining us for today's webinar discussing the multidisciplinary geriatric assessment. This will be a set of presentations by experts in the field on conducting an evaluation of physical, cognitive, psychological, and social needs of the older adult. We're pleased that so many of you are able to join us on this late August afternoon. First, let me provide a quick introduction to the platform for this session, which will also serve as a reminder for those who have participated in previous sessions. First, all microphones will be muted during the presentation. If your slides are not advancing, please push F5 on your computer keyboard. Also, please note that the icons circled at the bottom of the screen. Those icons are the gray and white icon with the CC indicated will enable closed captioning. After the presentation, we'll begin the question and answer period. Questions can be asked at any time through the red question and answer icon or over the open line through our operator, Joe. We'll select as many questions as time allows. All other questions and answers will be posted afterwards to the Resources for Integrated Care website. Joe, could you please take a moment to describe how participants can ask a question over the phone line?
Certainly. Ladies and gentlemen, if you wish to ask a question on today's call, please press star, then 1 on your touch-tone telephone. You will hear a tone indicating you have been placed in the queue. A voice prompt on your phone line will indicate when your line has been opened. You may remove yourself from the queue at any time by pressing the star key followed by the digit 2. If you are using a speakerphone, please pick up the handset before pressing the corresponding digits. Once again, that is star 1 to ask a question over the phone.
Great. Thank you so much, Joe. So there are several ways to ask questions, and we hope you'll take advantage of that so we can have a rich discussion. Additionally, you should have all received today's presentation in your email a few minutes ago. This will also be posted to the Resources for Integrated Care website by the end of the day. Next week, the post-recording will appear there as well. At the conclusion of today's presentation, we'll ask you to complete a quick survey on the webinar, and we hope that you'll take the time to complete that. We and our partners review all the answers to make sure the future webinars are a greater success. And please feel free to contact Rick, R-I-C, at lewin.com if you have any questions or additional comments. Now on to a quick overview. So this is the second of 2 webinars that were developed as a collaboration between Community Catalyst, the American Geriatrics Society, and the Lewin Group, and supported through the Medicare-Medicaid Coordination Office in the Centers for Medicare and Medicaid Services. A quick note about each of these organizations. So Community Catalyst, the organization that I work for, is a national nonprofit health advocacy organization that works with consumer advocates in over 40 states to bring the consumer voice to decisions that affect their health care. The American Geriatrics Society is a not-for-profit organization of over 6,000 health professionals devoted to improving the health, independence, and quality of life for all older people. And the Lewin Group is a healthcare policy and research consulting organization that's worked extensively with governments, provider organizations, and subject matter experts to support Medicare and Medicaid eligible beneficiaries and other high-risk populations. And together with CMS, we support providers in their efforts to deliver more integrated, coordinated care to beneficiaries. You can learn more about these efforts and find more resources at resourcesforintegratedcare.com. Just a quick note that this webinar is going to be 60 minutes of presentation from 3 different speakers, and then we'll be following by 15 minutes of Q&A. So at this time, I'd like to take a moment to introduce our 3 speakers to you. Our first speaker is Dr. Thomas Gill. Dr. Gill is Professor of Medicine, Epidemiology, and Investigative Medicine, and the Humana Foundation Professor of Geriatric Medicine at Yale University. He's a leading authority on the epidemiology and prevention of disability among older persons and one of the foremost experts in geriatric assessment. Our second speaker is Dr. Veronica Rivera. Dr. Rivera is an assistant professor at the Icahn School of Medicine at Mount Sinai in both the Brookdale Department of Geriatrics and Palliative Medicine and the Department of Family Medicine and Community Health. She practices outpatient medicine at the Coffey Geriatrics Practice at Mount Sinai and at the Family Health Center of Harlem. And our third speaker today is Linda Gillespie. Ms. Gillespie is the Aging and Disability Resource Director at the Central Ohio Area Agency on Aging, serving the Columbus, Ohio area. She's worked at the Area Agency on Aging for 26 years in several clinical and management positions, including oversight of the Medicaid waiver and Older Americans Act programs. Linda is a licensed social worker. For more extensive biographies for these speakers, check the Resources for Integrated Care website. Now, before I hand the presentation over to our first speaker, I just want to take a few quick polls to see who we have on today's call. So our first question is, which of the following best describes your professional area? You can select all that apply to you and hit Submit Answer. Okay. We're getting many answers, but they're still coming in. I'll give you another couple seconds. If you haven't already submitted your answer, please do so. Okay. And so it looks like we have a large percentage of folks from social work, followed by many from the advocacy community as well as in healthcare administration. Actually fairly well split, with the exception of pharmacy. So let's go on to our second question. And what is your primary role within your setting now? Again, you can select as many as apply to you and hit Submit Answer. Results are coming in. We'll give a few more seconds for people to participate. Okay, there's our results for today. We have, again, a pretty good split among all our areas between clinicians, consumer advocates, administrators, as well as others that we haven't defined here. Last question. In what setting do you work? Again, you can choose as many as apply to you and hit Submit Answer. We'll give a few more seconds for people to make their choices. Okay. We have a good deal of participants who are from managed care organizations as well as community health centers or federal qualified health centers. And we have many that we didn't capture, so we'll be interested to see perhaps in your surveys where you're from and what other interests you have. Great. Thank you all for participating. Now I'd like to hand things over to Dr. Thomas Gill to get us started with the presentation. Dr. Gill? Dr. Gill, you may start with covering what the topics are for today's presentation.
Yeah, thank you, Renee. This slide shows the topics that we're planning to cover in the next 40 minutes. Starting with principles of geriatric assessment, I'm going to hand things over to Dr. Rivera to discuss communication strategies. She'll hand things back to me to present on physical assessment. We'll next discuss cognitive assessment, psychological, social, quality of life assessment, and then conducting geriatric assessments first in the clinical setting and next in the home. So first, I'm going to take you through some of the fundamental principles of geriatric assessment. Next slide.
If the slide's not showing, perhaps, Jess, you could advance it?
I think there's one that may have missed.
Let's try that one.
Yes. So here are the 6 principles of geriatric assessment, starting with the goal, which is to promote wellness and independence. There's an intense focus on function, particularly performance-based function, and that may include gait, balance, and transfers. The scope of geriatric assessment is broad and includes multiple domains, including physical, cognitive, psychological, and social. The approach is inherently multidisciplinary, and an effective strategy to be efficient is to perform rapid screens that can identify potential target areas for a more complete evaluation. And to judge success of geriatric assessment, ultimately we're interested in maintaining and improving quality of life for our patients. Next slide. So I'm going to take you through 3 slides on rapid screening, starting first with functional status. And so the objective is to ask a single question or a smaller number of questions, do a more targeted assessment before doing a complete assessment. So depending on the response, the complete assessment may be implemented. We'll go back to the prior slide. Slide 1 of 3, please.
There you go.
There we go. So functional status, there are 5 questions here, and a yes response for any of the 5 would trigger a more complete assessment. We'd be interested in asking our patient whether, because of a health or physical problem, do they need help to first shop, 2nd, to do light housework, 3, to walk across a room, 4, to take a bath or shower, and 5, to manage the household finances. So a single yes response to any of these 5 items should trigger a more complete assessment. Next slide. So here's the second rapid screening slide, first focusing on mobility. A very effective and efficient test is that to evaluate mobility, and in terms of screening, is the time get up and go, in which a patient, you ask them to stand from a chair, to walk 10 feet forward, turn around, walk 10 feet back, and sit back in that chair. If they can complete that test within 20 seconds, they're in pretty good shape, and no further evaluation of mobility is indicated. For nutrition, there are 2 potential triggers that can be obtained first on self-report or on measurement, objective measurement of whether the patient's lost more than 5% of their weight in the prior 6 months, or if their body mass index is less than 20 kilograms per meter square. We'll talk more about BMI in a subsequent slide. For vision, a very quick and easy screen is just to ask the patient to read a newspaper headline and sentence while wearing their corrective lenses. And if they're having difficulty with that task, one would then go on to do a more complete visual assessment, and we'll come back to that in a subsequent slide. Next slide. Finally, in terms of the rapid screening for hearing, there's two potential strategies for a quick screen. First, whether the patient acknowledges hearing loss when questioned, or second, the whisper test, in which the clinician will whisper into the patient's ear at a distance of about 2 feet a letter number combination, such as A10. And if they cannot repeat that back, then that's abnormal, and that should trigger a more complete assessment. For cognitive function, the best simple single screen is the 3-item recall, in which you ask your patient, you give them 3 words, such as apple, table, penny, and a minute later ask them to repeat those. And if they're unable to remember all 3 of those items after 1 minute, that would be an abnormal screen and would lead to more complete cognitive evaluation. Finally, in terms of depression, the single most effective screening question is, do you often feel sad or depressed? And a yes response should trigger a more complete assessment for an affective disorder. So I'm going to turn this over to Dr. Rivera, who will walk us through the next few slides.
Hi, everyone. I'm going to now touch on communication strategies real briefly. Next slide. So these are just some brief reminders to keep in mind when communicating with your geriatric patients. Definitely important to establish a friendly relationship. So the basics are, of course, to introduce yourself, address the patient by their last name, especially with dealing with diverse cultures. Often it's very important for elders to be addressed in a respectful way. Face the patient directly, make sure to sit at eye level, speak slowly, and also ask open-ended questions. For example, what would you like for me to do for you today? Next slide. And a couple things to keep in mind, especially since sensory impairments are very common in our geriatric patient population. So hearing, in regards to hearing deficits, you may need to raise your voice volume accordingly. There are also some resources available, such as a pocket talker, which is a small amplification device, which are quite helpful in the clinic or hospital setting to communicate with your patients. Also, it's important due to vision impairment, if you're communicating in print, to make sure you give instructions in large print, or if you need to write any questions, also with large print. And then as you're, because geriatric patients can also have a little bit of difficulty answering questions, allowing ample time for your patient to answer. So next slide, we're going to transition to physical assessment with Dr. Gill.
Thank you. We'll move on to the next slide, and we've talked about a rapid screen, and now we're going to talk about what a more complete assessment may entail based on the results of that rapid screen. So here are the elements of a more complete physical assessment: functional status, nutrition, vision, hearing, and cognition. And we'll cover each of these in the next several slides. Next slide. But first, we're going to have a poll, and before we get into the more specifics, and ask the group to answer the question, which of the following is not considered a basic activity of daily living? So if you can submit your answer, and then we'll review those before we proceed.
And I'll just add that we're getting many of your votes in. In this instance, you can only make one choice, unlike the other polls we had. just give people one more second to make their choice. And Dr. Gill, those are your responses.
Right. So the plurality of the group had the right answer. It's cooking, and as we will discuss shortly, cooking is an instrumental activity of daily living, while the other 4 items here, bathing, dressing, feeding, and toileting, are all basic activities of daily living. So we'll cover that in the next slide. So at the top here are the activities of daily living. Sometimes they're called basic activities, sometimes they're called essential activities, but they include walking, bathing, dressing, transferring, toileting, feeding, and grooming. And these are activities that are essential to day-to-day living, and they, in most cases, need to be completed. If they cannot be completed by the patient, they'll need assistance to have those completed. The instrumental activities represent a higher level of tasks and include using the telephone, preparing meals, managing finances, taking medications, doing laundry, doing housework, shopping, and managing transportation. These tasks require physical capabilities and also cognitive capabilities. We'll move on to the next slide. I mentioned earlier the Get Up and Go test is a quick screen. What I would like to mention here is, in addition to timing that, as I mentioned, anything less than 20 seconds is a normal response. You can observe qualitatively the patient as they get out of the chair, as they walk 10 feet forward, as they turn, and as they return and sit down again, focusing on important aspects of their gait, on their balance, and their ability to transfer. The best single performance / objective test of function and physical capabilities is gait speed. So if there's only time to do one test, this is it. It's the strongest predictor by far of future disability and death. And you can gauge that through the Get Up and Go test, but if your patient was already standing, you can have them walk a certain distance, for example, in a hallway 50 feet, and if they can do that in less than 20 seconds, they're in pretty good shape. That would be a gait speed greater than 8 or 0.8 meters per second. Anything less than that is considered abnormal and warrants further evaluation. Lastly, there's a phenomena that's been gaining increasing visibility and credibility called life space. And that basically indicates how large the patient's world is. Are they confined to a single room in their home? Are they confined to their home? Do they go beyond their block or their neighborhood? You can envision this as a series of concentric circles, kind of indicating how far and how often they get around in terms of their mobility. Next slide, please. So for nutritional status, visual inspection is often a good starting point, looking for temporal wasting in the scalp, or perhaps looking at muscle mass in the thighs or in the shoulder girdle. More objectively, I mentioned earlier the measurement of BMI, body mass index, which is calculated using weight divided by height square. Patients are typically weighed every time they come to a clinic. Usually can rely on a single height measure, although we do recognize that older persons may lose height slowly as they age. The cut point that raises concerns for a low BMI would be less than 20. And as I mentioned earlier, monitoring patients for unintentional weight loss of greater than 5% over a 6-month period should be done routinely. Poor nutrition may reflect underlying medical illness, depression, functional losses, or potentially financial hardship. So if someone meets the BMI or the weight loss criteria, these are the areas that should be probed further. Next slide, please. For vision, it's generally understood that clinical disorders such as cataracts, glaucoma, macular degeneration, and abnormalities of a combination worsen with age. And this highlights the importance of visual assessment. First, by self-report, asking our patients about difficulty with driving, watching TV, and reading, particularly as it relates to the vision. And then performance-based testing, I mentioned earlier about the headline and single line from a newspaper or a magazine. And if there are difficulties there, that would trigger an assessment using the Snellen chart, which is typically placed on an office wall, or a Jaguar card, which can be just placed in front of the patient to determine what their visual acuity is. And if there are visual acuities below a certain point, perhaps less than 20/40, that with corrective lenses, that may trigger referral to an ophthalmologist or an optometrist, particularly if they have one of the disorders listed at the top of this slide. Next slide. Hearing loss is common, increasingly common with age among older persons, and impairments in hearing are strongly associated with depressive symptoms and depression, and also with social withdrawal, highlighting the importance of screening. Cerumen or wax is often builds up, and the first part of the physical exam in the setting of hearing impairment should be to determine if there's a cerumen impaction. Hearing loss among older persons is usually bilateral, with high frequencies being affected first, and abnormalities on the hearing screen or assessment should trigger a more formal audiometry testing in two settings. If the patient acknowledges hearing loss when asked, and then second, if they fail the whisper test that I mentioned earlier. I'm now going to turn things back over to Dr. Rivera, who will discuss the cognitive assessment in more detail.
Thank you, Dr. Gill. Next slide. So we're going to discuss why we want to screen for cognitive loss. This is a very common problem in our geriatric population. So most people with dementia do not complain of memory loss. So definitely important to screen for this condition. It's quite important because cognitively impaired older adults are at more risk for accidents, delirium, issues with medical adherence, and disability. And the prevalence, like I mentioned, is quite high. So after the age of 65, every 5 years, the prevalence doubles. So by the time we get to our patients who are in their 80s and 90s, it's close to about 50% prevalence. So very important to screen for and have that high on your radar. Next slide. Now I'm going to talk a little bit about how we actually screen for cognitive assessment. Before I get into the performance measures on this slide, I did want to talk briefly about a couple things to keep in mind. So one, with dementia, what we're screening for and looking for is short-term memory loss and impairment in other cognitive domains such as executive function, visual, spatial, motor, language. And so those are the domains that we're looking to screen for. And then also in dementia, those impairments have to have an impact on someone's function. So that's just something to remember. Also important to remember before you do your cognitive testing is to think about the screen in the context of the patient. So level of education is very important. So someone's screen may be very different if they have a PhD level of education versus second grade level of education. So how you interpret those results are very important. And then, of course, sensory impairments like hearing and vision loss can have an impact on how you interpret someone's test results. And then also someone's the language you're conducting the screening test in. So all of those can impact how you interpret. So quickly here, a couple things, a couple screens on this slide are the 3-word recall that Dr. Gill mentioned earlier. There's also the mini mental state exam, which is actually proprietary, but it is one of the more common screening tools we have used, and it's actually not as good in certain domains. So, for example, executive function, it's a little bit better tested in a test called the Montreal Cognitive Assessment, the MoCA, which I'm going to show in a few slides later. And then also the SLUMS, which is also available. St. Louis University Mental Status Exam is another tool that's around to try to screen for dementia. And then lastly, so a couple of tests that look particularly at executive function, a clock drawing test, and then also asking a patient to name all the number of animals that they know, or all the number of four-legged animals, to see how they do on that test. And for the animal naming, just a rough estimate, if someone scores can only name less than 12 in 1 minute, that would be a concerning test and would prompt a little more evaluation. Next slide. Thank you. So the Mini-Cog, this is a screening test that I really like and find very useful in my outpatient practice. It's very easy to do, doesn't take very long. It can be done by the physician or other people in the care team, and it simply involves a 3-word recall. So I think Dr. Gill mentioned apple, table, penny as common words that are used, and so ask them to repeat the 3 words. After you do that, you have them draw a clock, and I usually just give them a blank piece of paper, have them tell them to draw the clock with all the numbers and the time. 10 past 11 is the time commonly used. And that is a nice way to get you some information about someone's executive function, as well as visual, spatial, motor skills, and it's a nice screening tool. The way we score it is if someone has a score of 3 or higher, you give 3 points for the 3-word recall and 2 points for the clock. If the screen is 3 or higher, that's considered to be a negative screen. Again, remember though, you may interpret someone's results differently depending on their level of education and other factors that may impair their ability to do the test. Next slide. And here is just a copy of the Montreal Cognitive Assessment Test that's available online at www.mocatest.org. This is a not copyrighted test that's available in many languages online. This test takes a little bit longer to administer. You can see it's a little more in depth, but it tells you which domains you're testing, and also it's more sensitive for picking up mild cognitive impairment. So it's a better screening tool to pick up on slight cognitive impairment. So a nice resource to be aware of as well. Next slide, I'll pass it over to Dr. Gill.
Thank you. We have a few other areas to cover before we move on in terms of how to apply geriatric assessment in the real world in clinical settings. We'll focus here on psychological, social, and quality of life assessment in the next 3 slides. Next slide. So first with psychological status. The prevalence of major depression among older persons is often low, is 1 or 2%, although that value is higher in practice, being as high as 10%. But subclinical depression is much higher, and our older patients may not meet the DSM-4 criterion, but have depressive symptoms that perhaps warrant recognition and treatment. We talked earlier about the single best screening item. If that's a yes, the instruments that could be administered next include the Geriatric Depression Scale. There's an abbreviated form of that includes 15 yes or no questions, with scores of 5 or higher being abnormal. Something that's not as lengthy is the PHQ-2, which includes 2 questions, and if each of those are confirm depressive symptoms, then a more thorough evaluation is warranted. In older persons in particular, depressive symptoms and anxiety are often 2 sides of the same coin, so we should be cognizant of symptoms of anxiety and be aware also that our patients are often experiencing major life losses, deaths or serious illnesses and close family members, relatives, or friends that can often contribute to anxiety or depressive symptoms. Next slide. Social assessment includes several different elements, starting with wanting to understand our patient's ethnic, spiritual, and cultural background. These areas often contribute importantly to patient adherence to medications and to their values and preferences. It's also important to ascertain the availability of a personal support system, to know whether our patients are experiencing burden from being a caregiver for other family members or friends. The home environment, it's really difficult to understand how someone functions in a vacuum. We need to understand their function in their own environment, and often may query about the presence of potential hazards such as stairs and lighting and things of that nature. A surprisingly large proportion of our patients are being mistreated in some ways. That could be from self-neglect, or it could be from mistreatment from another individual, and there are often clues that may, come to attention during a clinic visit on a careful evaluation and examination. And advanced directives, we should try to engage our patients in discussions and understand what their preferences are for different levels or increasing levels of care, including resuscitation in the setting of serious underlying disorders or new acute events. And also want to remind folks that a minority of our patients may suffer from substance abuse, particularly alcohol, and that can contribute to a lot of health-related problems. And our patients often continue to be sexually active and at risk for sexually transmitted infections, and we should just be aware of that when patients present with genital urinary symptoms or other infectious signs or symptoms. Next slide. And lastly, quality of life often includes various aspects of physical, cognitive, psychological, and social function, the areas that we've been speaking about up till now. Instruments have been developed to try to integrate across those 4 areas, and one of those is the short form 36 health survey, which assesses physical function, limitations due to physical and emotional health, bodily pain, social functioning, mental health, vitality, general health perceptions. Each of those are scored on a 0 to 100 scale, with 100 being a perfect score for quality of life and 0 being the worst quality of life. I mentioned earlier about the importance of engaging our patients and assessing their preferences regarding medical care and goals of care, and that could be in the setting of having a discussion about advance directives or about other decisions that need to be made about diagnostic testing or treatments. And lastly, just want to reiterate the importance of culture and ethnicity on understanding of health and illness and how our patients experience those conditions. I'm going to turn things over again to Dr. Rivera, who will talk about incorporating some of these features of geriatric assessment into the clinical setting.
Great, thank you. Next slide. So we recognize how this can be at times overwhelming to think about trying to do a full geriatric assessment on patients who have multiple medical problems, are taking many medications, with many other requests. So one thing we did want to highlight is the importance of using your entire team, especially in the outpatient setting. Medical assistants, nurses can be helpful in doing many of these screens, for example, falls, depression, cognitive impairment. I know at my practice, our medical assistants, when they triage patients, screen for falls and also do the PHQ-2 and screening for depression. So important to think about using your team, and then also using your electronic medical record for assistance as well, building in templates and best practice alerts to make sure these screens and assessments are done over time. Next slide. So I wanted to just take a minute or two to review briefly one encounter I had with a brand new patient at a community health center here in New York, where I was seeing a brand new patient, 95-year-old Latina female with no known medical problems, who was presenting care for the first time. Actually, hasn't seen a doctor in many years. She's accompanied by her daughter, who was providing a lot of the history as well. And they brought her in for complaints of weight loss and memory problems, and again, no past medical history that was reported. Next slide. So important in the first visit to assess both the social and functional status. So I spent some time doing that. She was born in Santo Domingo, but has been in New York since 1935. She did graduate from high school and worked in a factory making dresses. She does have 2 children, one daughter who's mostly involved, who commutes from Virginia to spend time with her in the evenings. And in terms of her living situation, lives in an apartment alone with a 5 flights of stairs to walk into. In terms of her functional status, reports being independent in all of her activities of daily living. She does ambulate with a cane. And in terms of her instrumental activities of daily living, still going to the laundromat, preparing meals, and she is getting help with cleaning, shopping, and her daughter manages her finances. Next slide. So on the first visit, I did focus on her review of systems that were positive, of note weight loss, hearing loss, memory impairment, and the screen for falls was positive. So a lot on the first visit. I did take some time to focus on the cognitive screen, given the fact that she was 95. So next slide. This is an example of her Mini-Cog. So she had a 0 out of 3 recall, and the arrow is pointing to her first attempt at a clock draw, which, as you can see, is abnormal. And so I prompted her with drawing the circle for her, and she was able to get do a little bit of a better job with prompting. But this is an example of a quick screen. Again, given the fact that she has a high school level of education, this is concerning. So in future visits, it's important to follow this up. Next slide. We also referred her in the first visit to social work, again, using our team. She qualified for a long-term care program with Medicaid. She was able to get a home aid, also get physical therapy, some durable medical equipment. In terms of her hearing loss, on exam she had quite a bit of cerumen bilaterally, so worked over visits to remove some of the cerumen to help with the hearing, and then also continue to work her up in terms of her weight loss and cognitive impairment. Next slide. And future visits, also important to round up the rest of her assessment by also assessing for depression and vision screening, and again, reminding that you may not get to all of your geriatric assessment, thorough assessment on the first visit. Next slide. So just some quick tips, trying, again, to remember not to get overwhelmed with all the different aspects of the complete geriatric assessment. You can do these over time, and your patients will continue to be coming back, especially in the outpatient setting where you'll have time to do some of these assessments, and important to use your team. So at this time, I'm going to pass the presentation over to Linda Gillespie, who's going to discuss conducting in-home geriatric assessments.
Thank you. Next slide, please. Okay, so many of the principles and techniques that you heard Dr. Gill and Dr. Rivera talk about are also applicable when conducting in-home assessments. The added benefit of the in-home assessment is that the assessor can observe the environment and the family situation and address potential barriers to following physician's orders and minimizing health and safety risks. The assessment collects information about an individual's current situation, functional abilities such as activities of daily living and instrumental activities of daily living, and strengths, problems, and care needs. In addition, we will often ask about social history, family involvement in the past and currently, work history, hobbies, and goals and preferences. Next slide, please. So the in-home assessment is often conducted by a registered nurse or a licensed social worker who has prior experience and training in working with older adults. The professional is knowledgeable of the availability of and eligibility for home and community-based services. And the assessment process can often lead to linkage with community resources that will assist the older adult in remaining in the community and in complying with physician orders. Next slide, please. The comprehensive assessment itself is pretty in-depth. It will look at medical history, diagnoses, prior hospitalizations, and in particular recent hospitalizations or emergency room visits. The assessor will look at medications, what's been prescribed, are the medications organized, are they clearly labeled, are the medication bottles filled or are they empty? Does the individual or the caregiver understand the reason for taking the medications and how to take them properly? Does the individual seem to be compliant with taking their medications? Disorganization or a lack of compliance may indicate the need for a nurse to assist with setup and monitoring. The assessor will also look at medical equipment, durable medical equipment that may be present in the home or may be needed, such as grab bars, a shower bench, hand railings, etc. The assessor will look at other environmental aspects such as stairs. Are the stairs steep? Do they have handrails? Are there other physical hazards such as throw rugs, inadequate lighting, flooring? Is there evidence of hoarding, which is something you'd probably know the minute you walk in the door? Also, something that is a big concern is the evidence of rodents, roaches, and bed bugs. And bed bugs in particular over the last few years have become prevalent and are extremely difficult to exterminate. And so this has become a big issue not only for the person living in the home, but also caregivers who are attempting to assist with services. Next slide, please. During the comprehensive assessment, the assessor will look in the refrigerator, look for food. Is there food there that's not expired? Is there an adequate supply of food? Are there working utilities and a telephone? We will also, in the home setting, in addition to what happens in the physician's office, ask about advanced directives, such as health care, power of attorney, durable power of attorney, guardianship, and we will encourage people to complete these kinds of documents and share them not only with in-home providers but also with their physicians. Is there a need for assistance with managing finances? Oftentimes, having somebody help with paying bills and doing banking can be the difference between somebody being able to stay in their home or not. Is there an ability to get in and out of the residence, both in terms of in and out of the doors? For example, are there steps or is there a ramp that's needed? And then also the ability to get around in the community. Is there transportation to medical appointments or non-medical visits such as grocery stores, church, other types of trips that people would like to take? And is the person isolated, and what can be done to help decrease that isolation? Are there signs of dementia and depression? Next slide, please. We will look at the support system. Are there caregivers available living in the home or nearby? And what's the ability of those caregivers to continue assisting over time? We know that over 80% of the care that people receive is through the informal supports, family, friends, neighbors. And one of our goals is to provide some assistance and respite for those caregivers so that they can continue to provide care. We'll also look at who might be in the home or visiting regularly who might be creating difficulties, such as problems with caregivers, formal caregivers who are coming into the homes. Sometimes home care agencies have no problem at all in providing services to the older adult, but there's some kind of a conflict with somebody else in the home. And we will try to negotiate solutions to those types of issues. Are there signs of neglect or abuse or substance abuse? We are mandated Adult Protective Services reporters, and we will work with Adult Protective Services together to try to improve a situation so that somebody can continue living in their home. Next slide, please. So when it comes to care planning for an individual, one of the first things that we need to ask about and consider are the goals and preferences of the older adult and the caregivers. And we also look at cultural preferences, too, and as much as possible try to accommodate those. But one of the main goals to ascertain right from the beginning is, does the person want to stay home, and are they able to stay in their current home, or are there other alternatives that need to be looked at? For example, maybe an apartment instead of a house, or assisted living instead of their own residence. The assessor will review available community-based care options, and in many communities there are a variety of options, including Medicaid-funded programs, community agencies that will provide services to older adults that are 60 or older, and there are no financial requirements for those types of programs. In Ohio, we are fortunate to have county senior service levy programs in many of our counties where the voters have approved property tax or sales tax levies that support services for older adults. And these are often a good way to get services in for people who are not Medicaid eligible, or maybe not quite as impaired as some of the Medicaid programs require. But the assessor has a good understanding of what is available in the community and what the eligibility criteria are for those programs. And the assessor will link people to those programs and provide as much assistance in actually receiving services from those programs as the person wants to allow the assessor to help with. And many community-based programs include ongoing care management to ensure that services are meeting needs and that the person's health and safety aren't being compromised by staying at home. Next slide, please. So care management standards vary among programs, funders, and the population served. The standards may be dictated by the risk level of the older adult, for example, medical or functional frailty and health and safety concerns. Usually care management occurs with a mix of telephone and in-person contact, which may be monthly, quarterly, or more often. The standards that a particular program imposes are always minimum standards and need to be adjusted based on any kind of an event that might be occurring in which a consumer actually needs more attention. Next slide, please. So how do you locate community resources? Every community is different in terms of what's available and waiting lists and eligibility criteria, et cetera. But a good place to start is to contact the Area Agency on Aging serving the region where an individual lives. There are close to 700 area agencies in the United States, and area agencies are very different from each other. Some provide primarily information, referral, and linkage. Others are actually administering programs and provide ongoing case management. But at a minimum, all area agencies offer information, assistance, referral, and linkage, as well as free in-home consultations to individuals who are trying to determine what their options are. And the way to find the closest area agency to an individual is to use the Elder Care Locator. And I've listed both the web address and the phone number for the Elder Care Locator. And when you go there, you just put in a person's city or zip code, and it'll direct you to the nearest area agency on aging. Next slide, please. Okay, so quickly I will just go over a case study for you, and this is CH. Mrs. H is a 75-year-old widowed female. She lives alone, but she has a niece who visits daily. She also has 3 grandchildren who visit often but aren't really providing any assistance. The niece is the primary caregiver and assists with daily care. Mrs. H has limited financial resources. Next slide. So her primary diagnosis is congestive heart failure. She's also obese and has a history of prior back and knee surgeries. She does see her physician regularly. She needs hands-on assistance with bathing, dressing, toileting, and locomotion due to weakness. She has a shower chair, a walker with wheels that she uses primarily outside of her home, and a raised toilet seat. She also has a straight cane that she uses in the home. Next slide. The assessor did not observe any environmental concerns, but did note that Mrs. H is at risk of falls due to her obesity and other problems, physical problems. She denies feeling depressed, and there weren't any behavioral issues observed. She's oriented to time and place. Her niece handles her finances and shopping and laundry and meal preparation. There were no advance directives or power of attorney in place. And her niece is definitely in need of some assistance to reduce her own stress level. She's living in another location and visiting daily and providing quite a bit of care. Next slide. So Mrs. H currently receives a home health nurse to set up her medications and monitor her vital signs and evaluate for signs and symptoms of congestive heart failure. Mrs. H and her niece are requesting personal care services, a homemaker, an emergency response system to be there in case she falls because she is alone at times, and also incontinence products for times when she doesn't make it into the bathroom quickly enough. Mrs. H financially qualifies for a program funded by Medicaid, and she will get services through that program. The assessor will help her apply for that program and make sure that everything's in place for her to get services as quickly as possible. She will receive ongoing care management by a nurse or a social worker to ensure that her needs are being met. Next slide. And I will turn it back to Dr. Rivera.
So just in summary, just as a reminder, the focus of our geriatric assessment is predominantly on function. Successful assessment does promote wellness and independence. And strategies that enhance communication with older adults should always be used. And, of course, our comprehensive assessment includes the following domains: physical, cognitive, psychological, and social aspects of health and wellness. Next slide.
Great. Thank you all, Ms. Gillespie and Drs. Gill and Rivera, for the wonderful presentations. This is Renee Marcus Hoden again, and I just wanted to remind people that in the time remaining, we're going to turn to a few questions and answers. We've received many via the chat function, so thank you all for using that while the presentations were going on. We'll try to get through as many as possible. However, and you can keep sending those if you'd like. However, you can also use the AT&T operator to ask a question. And Joe, would you please remind the participants how to do that?
Certainly. If you would like to ask a question on today's call, please press star, then 1 on your touch-tone telephone. You will hear a tone indicating you have been placed in the queue. A voice prompt on your phone line will indicate when your line has been opened. You may remove yourself from the queue at any time by pressing the star key followed by the digit 2. If you are using a speakerphone, please pick up the handset before pressing the corresponding digit. Once again, please press star 1 at this time if you have a question.
Great. Thanks so much, Joe. Let's start turning to a couple of the questions that came in via chat, and we'll go back to Joe in a moment or two to see if there's any by phone. So the first question is sort of a bundle of two questions that came in, and I believe they're for Dr. Gill. There was a request to clarify regarding the gait speed issue. So could you please clarify and review the normal gait speed, as in how many feet per second? And then secondly, I believe you said that gait was a predictor of disability and death, and the participant would like you to elaborate on the aspect of it being a predictor of death.
Right. So there are different ways of assessing gait speed. In the literature, it's often done meters per second, and I know that's not the way clinicians in the States often think about things in terms of meters, but I'll present that first. Typically, anything slower than 0.8 meters per second is considered slow and worthy of further evaluation. In terms of the usual metrics of feet, I mentioned, I think, during my comments that 20 seconds to walk 50 feet. Anything under 20 seconds would be considered within the normal range. So that's 25 feet over 10 seconds, or 2.5 feet per second. Anything slower than that would be equivalent to 0.8 meters per second. And the second question related to the evidence of gait speed predicting other outcomes? Can you?
Just in asking for an elaboration on how gait is a predictor of death as opposed to disability.
Yes, I mean gait speed. I mean our understanding is that it's really a measure that integrates across many different functional areas, not just physical, but there's a cognitive component of that. There's a balance component. There's a strength component, and it's really a very effective integrative measure across those domains. And each of those domains contribute predictive ability for outcomes such as death. So gait speed, by encompassing all of those, has been demonstrated to be really the most robust predictor of mortality. And essentially every other relevant outcomes in older persons, including admission to a nursing home and the onset of severe disability.
Great. Thank you so much for the answer. Dr. Rivera, the next question, I believe, falls to you. You talked about cognitive screening, and the participant wanted to know about follow-up if the patient fails the cognitive screen, and particularly if that patient has limited speaking capabilities or if English is not their primary language. Could you speak to that?
Sure. So this is definitely a complicated area. What my approach is, as I mentioned, I usually start with the Mini-Cog, and if that is abnormal in the outpatient setting, I usually follow it up with the Montreal Cognitive Assessment screening tool or the Mini Mental Status Exam, and to use that to get a little bit more information about which domains are impaired. And it is, there's also, again, these are screening tests. If there are a couple of indication or instances where I would consider even further testing, like neuropsychiatric testing, which is much more in depth, often about 2 hours worth of testing in all of the different cognitive domains. So if someone has a very atypical presentation, either at a younger age than expected, or if you're dealing with a complex situation, so for example, someone who's investing money and maybe shouldn't be making those types of decisions, and you want more information to sort of illustrate someone's where they're having significant cognitive impairment, you could also think about referral to neuropsych testing, although that's sometimes limited depending on where you're practicing. The conversation about dementia is a more in-depth conversation, but I also follow up with some basic labs to rule out reversible causes for dementia, like B12 deficiency, hypothyroidism, if indicated, syphilis screening, those types of things. So but in terms of the initial screening, I start with a Mini-Cog and then follow it up usually with a Mini-Mental or a MOCA. When you do have issues with level of education or communication difficulties due to language, so there's a couple things to keep in mind. First, if it's due to language, very important to try to get the screening test done in the person's native language. So, for example, Spanish, I might administer my cognitive assessments in Spanish, and if you have to, this is difficult if you have to use a translator line, so definitely encourage you to try to get in-person translation, interpreter services, because it is very difficult over the phone if you're able to get those resources. And if the issue more is level of education, it is, sometimes you're going more on the history that's provided by family members who are involved, and so there are a couple other screening tools out there that are not in this talk. One example is called the AD8 dementia screening interview, and it's 8 questions that you can ask to a family member or other person who's involved to ask them more about a person's function. So, for example, things like remembering appointments or difficulty learning how to use a new tool or gadget. So that's another tool that is sometimes used, but it's definitely more challenging when you have the complicating factors of language and level of education.
Thank you, Dr. Rivera. Jill, why don't we go to the phone? We have many more questions that came in via our platform, but I wanted to give a chance to anybody who may have come through the telephone line.
Certainly. We do have one question, caller. Please go ahead. Your line is open.
Yes, hello?
Yes, go ahead with your question.
Oh, yes. We're calling from community health centers in California. And actually, we already established a comprehensive geriatric assessment, and we have a group of people run by the geriatrician, social worker, and optometrists and podiatrists. But so we've been having problems with the billing part, and I don't know if any of the people that provide this lecture knows about how to deal with that part, because we've been basically billing for just one visit. So I don't know if any of them will be able to tell us if the team is, included with different specialties, if there is any way to bill for each visit.
Okay, I'll ask our speakers. Would somebody like to jump in with a response to the question on billing for assessment?
I do know that, Medicare, just within the last few years, now supports a wellness visit,
yes,
annual wellness visit, and so they require that some of the components that we spoke about today of geriatric assessment be included in those assessments. So during that visit, so I think that's one strategy in which you'll get reimbursed through Medicare. What we also highlighted is that often it's not realistic to complete an entire geriatric assessment during a single visit. And so recommendation is often to focus on one or two components during a single visit. And often patients are coming back on an every 2, 3, 4 month schedule, and you can have this geriatric assessment done on a rolling basis. So those are two strategies, I think, in which physicians or clinicians can get reimbursed for a geriatric assessment.
Dr.
Rivera may have other suggestions.
No, I agree. I think I'm guessing that your question is also about getting reimbursed for the other members of the team's work. Is that
right?
Correct? Yeah. So, and unfortunately, in our current system, that's very challenging. So, if there's a way to have a visit that's done, for example, by one of the other members of the team that's with a physician supervising, again, in separate visits, that may be able to increase your billing. But if the whole team is doing it all at once, I can see how that would be, you can bill for the highest level, but then that's only one visit.
Thank you both, Drs. Rivera and Gill, for answering the question. I see that we are actually at the end of our time, and we didn't even get close to answering all the questions that were put through our webinar platform. So I just wanted to let everyone know that we will be taking the time to look through those questions and answer each of them, and then they'll be posted on the Resources for Integrated Care website in the coming weeks. So I want to end by just thanking our speakers and everyone else on the call today for your time and for your participation. I do want to remind you that we have a final survey about the webinar so that this will help us to continue to provide quality webinars. As a reminder, if you have any questions or comments, please email Rick, R-I-C, at lewin.com, and again, the webinar presentation will be available for download on that same website, on the website Resources for Integrated Care, by the end of today. Have a great afternoon, and this concludes our webinar.